No, that's just endocrine and cardiovascular. I think it says it on the syllabus.
It does, but
Yeah.
you don't know.
No, I'm trying to stick what's on the syllabus. All right, so we'll get into this. What is today, guys? Today's Monday. Holy shit, only beginning of the week. All right, so Tuesday. You probably won't get these back, guys, until next Monday because I have another exam to write and give, and I haven't finished grading another set of exams I gave at Salem Central. So it'll probably be a week before you guys get these. Plus, I got to for some kind of a lab practicum you guys have on a Wednesday. Something like that.
Are you serious?
We can forego that? Oh, okay. Yeah. All right. So I'll probably get it back on Monday. I do know there's one question I'm going to throw out because my brain decided to be an asshole. It was like really cool. I liked it, but I thought, no, fuck, that's not fair after I read it. And that was the one about the percentage of water of whole blood. Right?
What was the answer? Oh,
It's actually about 50.6%.
Oh.
It's 92%, not 55%. But if you wrote a number down, I'll give you credit for it. Right? If you left that blank, you get no credit. Right? But if you wrote a number down, I'll give you guys credit
If
for
you
it.
got it right, can you get like
I might give you a bonus point, yes. Okay. All right. So, ladies and gentlemen. All right, let's get on with this. So, once I'm done, you guys can decide what you need to do. All right, we're going to begin looking at respiration and how we get oxygen out of the lungs and such, but we have to do a little anatomy, right? And as was asked, keep in mind what the syllabus says. This stuff is not on your exam on Wednesday, because it's not fair. I mean, I wouldn't give it to you tonight. We have an exam on Wednesday for it. So this will be on the next big lab test, which is the final itself in a sense. Keep in mind the same idea of the heart. Right? We had this serous membrane that surrounded the heart. Right? Now we have serous membrane that lines and covers the lungs. And it's the same idea, right? Serous membrane, two layers, parietal versus visceral. The parietal is inside the chest cavity. The visceral is literally on the lung tissue. There's a cavity between the two. There'll be some fluid found in there. So it's the same idea as the heart. We just, instead of using parietal pericardium, now we say parietal pleura. And we say visceral pleura rather than pericardium. Pleura, like pleurisy, right, refers to lungs. To give you a picture of this, then we can look at this little diagram. And so this would be your chest muscles and bones. So there's the parietal layer, there's the space, and this is the visceral layer right on top of the lungs. And they're trying to show you that over here as well, where this outer layer would be the parietal, right, up against the underside of your rib cage. There's a bit of a space right there, and then you have the visceral part right along through here. When we break out for you guys on Wednesday, what's called a pluck. It's a trachea, esophagus, heart, pericardial sac all together, maybe a bit of diaphragm tissue, and you're holding the lungs in your hands. So I'm going to ask you to come by and hold the lungs in your hands. Imagine holding a big pile of meringue from a lemon meringue pie. That's what it feels like. It's that light and airy. But what you're actually holding, what's actually touching your hands is the viscera pleura. You're not going to be able to peel it off of the lungs and actually ripping the lung tissue to shreds. But that's the actual tissue that gives it a nice little glossy, shiny feeling. I'll have you dip your fingers in some water, because you have gloves on, of course, and you can feel how slippery and slimy it is. That allows the lungs to expand and contract up against the parietal layer without creating lots of friction with this. But we're also going to notice that the parietal layer is actually connected to the diaphragm. It's literally connected. So if the diaphragm moves, we'll be tugging on that parietal layer as well with this. Now, we know we have two lungs, right? There's a vocabulary here. You got to kind of organize this. We have a left lung and a right lung. But then each lung is comprised of lobes. So you're going to have the left lung with 2 lobes and the right lung with 3 lobes. And then we got to name the lobes. Well, let's do the left one first. The top lung, or lobe, let's call it the superior one. And there's one on the bottom, we're going to call it the inferior. That's like common sense, right? Same for the right. The top one is superior, the bottom one is inferior. So why not call the one in the middle lobe? Easy. But then we have this fissure, this crease in the tissue. Think about 241 for a moment. Think about brain tissue, right and left hemispheres. and there was this gap that ran along the length of your brain. Remember the name of that gap? The longitudinal fissure, right? So we have these fissures that separate the lobes. We have a horizontal because it goes horizontally, and we have an oblique fissure because it goes obliquely, right? So they're named for their orientation. Then you realize the left, well, it doesn't have a horizontal because I don't have a middle lobe. I still have an oblique fissure, however. So the only thing unique about the fissures is that the right has a horizontal, the left does not, and the right has one more lobe than the left. Then there's this place for your heart called the cardiac notch that's associated with the left lung, but not the right lung. All right, your fun task, because you guys love to divide up and organize information. There are two ways we can talk about your respiratory pathway. One in terms of structural organization, upper versus lower respiratory tract. And you guys recognize this term, upper respiratory. How many of your friends have ever had an upper respiratory infection, right? Now you know what they're dealing with, right? Larynx or a pharynx or nasal cavity, somewhere up there you have an infection. So that's my division of labor. From the larynx up is upper, and then from the just below the larynx on down is going to be my lower respiratory tract. That's not really as fun as over here in the yellow boxes, which is a functional classification or way of organizing our respiratory system. Now, the conducting zone simply means that part of our respiratory tract that moves the air but does not do any gas exchange. Right? It moves the air but does not do any gas exchange. So look at this big piping system we have in our ceiling, right, for heating and air conditioning. The air moves through it, it's conducting the air, but we don't do any actual exchange till we get to where the vents are, right? So we don't let the room get hot or cold from this part of the structure, we don't let the room get hot and cold from that part. Well, that's the functional part of gas exchange, that's this. This is where we do gas exchange. O2 goes into the blood and CO2 is going to come out. We're going to learn all about how we do that. That means then, according to the diagram, that what part of my structure is actually involved with the respiratory zone. That's respiratory bronchioles, the alveolar duct, and then the alveoli themselves, which we're going to zoom in on a little bit later. All right. We're keeping this really simple. Don't panic. First, go back to your favorite tissue in 241, the pseudostratified ciliated columnar epithelium. It's in your nasal passageway, right? That's going to be your nose, your nasal cavity. It'll be in your nasopharynx, which we'll point out to it in a moment. Right? It'll be in your trachea, that's your windpipe. Right? And then all the way down to the lobar bronchi. So from the trachea down to our lobar, which right now means nothing to you, but it will by the end of tonight. That's all we're going to do for that. We're skipping the middle two. Just not a class in histology. But they're going to come down to here, right? The actual wall of your lung tissue is simple squamous. That makes sense because if you think about the size of the cells, right? The thinner the cell, the easier it is for things to diffuse through them. So I don't want cuboidal cells, I don't want columnar cells, I want my thinnest possible tissue. So our lung tissue, where we do gas exchange, is going to be made up of simple squamous. And we'll see that toward the second to last slide in our anatomy notes for tonight. We're skipping the middle two. Well, let's look at where we find some of this tissue. This is what's known as an open-faced view, because we're kind of cutting your head in half and looking inside your nasal passageways, in your throat, and in your mouth. And if you think about these structures here, two of these should sound familiar to you from 241, when you guys had to do the skull, right? You had to find those nasal concha, and you had an inferior and you had a middle one. So when you guys, this is probably easiest to see, we're looking through the nose, right? And you found those little bony structures inside the nose, right in there, right? That's these guys. So the lowest ones, there we go, the lowest ones here are the lowest ones here. The ones right above them Right? You can barely see by sticking your finger in it up his nose. Then you have ones you really couldn't see. Well, they're called the concha, and their purpose is to stir the air as it comes in your nose. You want to create turbulence. I want to toss that air around inside my nose. Now, we remember from the previous slide about epithelium, right, that in my nasal cavity, I have pseudostratified ciliated cells. I have this stuff in my nasal cavity and in my nasal pharynx. Well, that's right along in here. You have pseudostratified tissue with goblet cells, mucus-producing cells. I have these concha that stir the air. And what you think about is, because of that epithelium, it's like flypaper inside your nasal passageway. Flypaper is really sticky. This is your own little version of a biological HEPA air filter. Has anybody in here ever been in a really good dust storm?
Oh yeah.
All right? And you blow out, the desert comes out of your nose, right? When you blow your nose, right?
Yeah.
Why does the desert come out of your nose? Why didn't the desert just settle inside your lung tissue and you're walking with a big bag of sand in your lungs? Because all the snot that's in your nose is like flypaper. And the dirt, the dust, the pollen, the sand granules actually stick to the mucus. And then you blow your nose to exhale out that foreign debris. I don't want that stuff going down into my lungs. So all of this, and even your trachea, is lined that pseudostratified to create lots of mucus to act as flypaper. And that's why I'm stirring the air, to make sure I get all the dirt, all the dust, all the pollen particles. But it also helps to warm the air and to moisten it. Especially if you live in dry, arid environments. I don't want dry air going into my lungs that'll create a moisture gradient, begin to crack my lungs from the inside out. So I want to moisten. I get that moisture by coming off of the mucus that lines my nasal cavities. Now, so you're kind of picturing in your mind that epithelial cells, right? And the goblet cells, oops, that are in them, these little guys, that produce mucus. And I want you to appreciate how hard those little guys work. Think about the last time you had, or if you have a friend who currently has a stuffy nose. Did you ever blow your nose so you could breathe? And how fast you can finally breathe? You go, oh, I can breathe, thank God. How long does that last for? About a lousy 6 seconds, right? And then boom, you're all plugged up again. Right? Because the mucus is actually there as your friend. And your body says, you just rudely blew me out. I'm here to protect you. And yet you get rid of me, so I'm going to make more snot. It's actually there to prevent you from getting sicker. And yet we blow it out because it helps, it's a hindrance for us to breathe through our nose. You do the same thing with a fever. Your body works hard to make you have a fever. And what do you guys do? You take aspirin to lower it, right? But your body wants it to kill the germs. And your body's going, I just made this for you. I'll burn all these calories to help get you warmer, to kill the bacteria. And you lower my thermostat down. Not nice of you. So speaking of germs and dirt and dust, we have these things called tonsils. Right? There's one called the pharyngeal, way back here, up the back part of your nose. And you have two more, little red dots, called the palatine and the lingual. The palatine are in the back of the throat where your palate is, in a sense. And then the linguals are with the tongue, the very base of the tongue. And these three groups of tissues, known as tonsils, are immune tissues.
What if you don't have those anymore?
Well, these are known as your adenoids. You probably still got rid of those, right? These you would probably still have. They took those out of you as well?
No.
Okay.
But the tonsils and adenoids though.
Well, that means then you're a little more susceptible to invading pathogens. You still have one last hope in terms of the oral cavity, these tonsils back here, right? But think about what normally goes through your nose and down back here, back to the back of your throat, and what normally goes through your mouth, right? Normally food or air through the mouth, right? It's a dual purpose passageway. So I want lots of immune tissue there, so in case the air I breathe has dirt in it, or the things I'm eating has pathogens in it. I mean, once in a while, you know, usually the food goes this way, right, out through your nose. But they're all connected, so I want lots of immune fighting material there. So we have 3 sets of tonsils, but then we have one major group, one region called the pharynx, that we're going to divide into 3 sub-regions. The nasopharynx, the oropharynx, and then the laryngopharynx. We got to figure out now where each of these begin and end, so we have some little division lines for you. We have 2 slides for it. There's this one and then the one after this. So if I draw a line in my mind, right across, basically around where the uvula is, that's that little thing that dangles in the back of your mouth when you go and look in the mirror, like a little punching bag thing that hangs down. If I, in my mind, draw a line right across to my neck and go upwards, right, all of this is nasopharynx, right along up through there. That means I can probably guess that my oro starts right here as well, because it's in line with the mouth, right? And people who speak are orators, so oropharynx is in line with the mouth. Just come right across through here. I'll be in there. Now my only question is, where does it stop being the oropharynx? Come right about here where the hyoid bone is. And in between these 2 blue lines is where we're going to have our oropharynx, right along in the back of the tongue, back of the mouth region. It's actually occupying your palatine tonsils. So when you go home tonight and look in the mirror and go, oh, and you can see the little bumps in the back of your throat, you're staring at your oropharynx. If you pick your nose far enough, you're going to be getting to the nasopharynx, which I don't suggest you really try and do. The smallest one is this laryngopharynx. And it's going to come down to right about here, just sort of just below the entrance, or the common entrance, if you like, for the trachea and esophagus, right back in there. And so we can look at it on this slide that I gave you guys, kind of color-coded, right? The orange is the boundary of the nasopharynx. The blue is the oro, like I said, right in line with the mouth for orating, occupying that palatine tonsil, right? Coming down about at the level of the hyoid, right through here. And then the common entrance to the esophagus and the trachea is occupying where the laryngopharynx is in that region. And that gives us the 3 major areas of our pharynx. You practice spelling those, as well as pronouncing them, but mainly spelling them. Now, in terms of your larynx, which is your, quote, voice box, we have 3 major groups of cartilage that we're going to focus on. This thing here called the epiglottis, and this is the anterior view, so you're looking straight this way. It's a flap door that goes backwards. So if I look at it from the side view, from that earlier diagram, it's this little trap door right here. And how do I know that's the epiglottis? Because it says so right there, right? But now it's a trap door. So when you try and swallow food, we get over here, right? Muscles will help pull the epiglottis down so it covers the trachea. So food will only go down the esophagus, usually. Right? Think about in your own experience where it screws up, right? And what little you need to go into your windpipe to make you cough your head off for the next 5 to 10 minutes, right? Just a drop of liquid, and you'll be coughing quite violently because your lungs go, what the hell is this? Let's get it out of here. You gotta try and push it up with air volume and air mass. So we need that trap door called the epiglottis. And then we have 2 other cartilaginous structures. You have your thyroid cartilage, aka your Adam's apple, this thing you can feel right there. And then right below it, if you feel the tip of it, there's a bit of a notch just below it, right about there. And that notch is this notch. And right below it then is the cricoid cartilage. Now if you notice, I have 2 red boxes and 1 purple box. So apparently they're not all the same. This is elastic cartilage. These 2 are hyaline cartilage. So the purple is elastic, the reds are hyaline cartilage. And I'm hoping in your mind, you all of a sudden you had a flash of what it looks like in your mind, right? The difference in histology. If not, we'll work on that. Now, these things here are called the trachea. Well, The pipe is the trachea, but these are actually tracheal rings. They're cartilaginous rings. They're C-shaped, like my hand, literally like a horseshoe. And we're looking at them this way. But if I took my neck and turned it around so you can see the back side of my neck, it's this. And then you realize they don't go all the way around. They are a C-shaped band of hyaline cartilage. And you get about 15, 20 of them. But they're also made of hyaline cartilage, just like the cricoid and the thyroid cartilage is.
What were those called?
Call them tracheal rings,
Okay.
or just C rings of the trachea. There's kind of a C shape in structure. Now here's where I know that I'm definitely getting older, and unfortunately old analogies really don't work nearly as well as they used to. So I was raised working on car engines. I used to do my own work, even starting in elementary school. And you guys have this thing called a radiator hose that goes through a radiator, right? And inside is this metal coil, right? And there's a coil. Why is there a coil in the hose? Because when the engine's running and the pump is working, it creates a vacuum and begins to suck the hose shut. Well, how many of you have actually seen a radiator hose? All right, in the last 2 years, that's quite fortunate, right?
Doesn't
Right?
have one.
I haven't popped the hood of my car since I bought it in 2010. I have not seen my engine, literally. I used to do all my own work until I bought this damn new car. Because I can't get my hands in there anymore. Can't even see the ground, for God's sakes. But here's my point. Take a straw. Imagine a long 7-Eleven Slurpee straw. Pinch the end of it. Now suck on that straw. What do you know from life experience is going to happen to that straw? It's going to seal shut, right? Well, this is a closed straw. It's closed in your lungs. So every time you inhale, the trachea wants to seal shut. That would suck if you're trying to breathe air in. So these tracheal rings maintain the trachea being open. It prevents them from being closed every time you inhale. Otherwise, I wouldn't be able to inhale at all. So they're structural reinforcement. And your esophagus is right behind them. Otherwise, everything else, I don't care. All right? Do not worry about all the little ligaments and everything else. We're just looking at the 3 major boxes, what they're comprised of, and what their purpose is. So speaking of your voice box, really there's no such thing as vocal cords. They're actually a fold of tissues. You really want to say vocal folds. And it's these fold of tissues that vibrate when air passes by them. And that's what creates our voice. And that's all we're going to worry about. We're not going to do any of the anatomy. Right? Just the fact that vocal folds, not vocal cords, are responsible for voice production, for sound production. And they vibrate. If I can find it, there used to be a really cool video of, I think it was Steven Tyler, who went through the scale. So they had a camera down by his larynx that showed his vocal folds change as he went up and down the scale. Really pretty cool to look at. Otherwise, memorize none of the structures that are in here. All right, let's start talking about this conducting system. I mean, I've got my thyroid cartilage, I have my cricoid cartilage, I have my rings of cartilage going down my trachea, and all of this, remember, is hyaline cartilage. And then like in arteries, right? Remember the general rule is when an artery branches, what do we do to the name?
Change it.
We change it. We do the same thing here, right? Here it comes down the middle, it branches, so I'm going to have a left and right primary bronchus. Bronchi plural, bronchus individual. This one, if you look at carefully at the picture, is going into purple stuff. Well, that's your lung tissue. So you realize that the primary branches lead to the lungs. The primary branches will lead to your lungs. So if I want to remove a whole lung, I have to cut your primary bronchus and pull the whole lung out. Now the rule is, when the branching occurs, we change names. So I look down here and I can follow the primary here, and then there's my branching point. It's going to go up this way and go down this way. So this and that, right, are part of the secondaries. Because it's the second set of branching in this conducting tissue. We do the same thing over here, but they're a little sloppy in how they do it, so we're gonna not worry about the naming just yet. But trachea branches into two primaries, right? A left and a right. The primaries will branch into secondaries. Little pop, fine, no pop quiz. What?
Are all of those secondary bronchi coming off of the left primary bronchi?
We only have
Like
that one and that one.
Okay.
That was my next thing,
Oh.
right? Primaries lead to lungs, secondaries lead to lobes. How many lobes do you guys have on the left? Do you remember? Just two. So you only have two. You only have two secondaries. How many lobes on the right side? So we're going to have three secondaries on the right side. Because each secondary leads to a lobe. Each primary leads to a lung. And we have a better diagram than this for that level of depth. Let's look inside our trachea and look at what they're pointing at, where it says respiratory epithelium. Right? Remember the definition of epithelium? Tissue that lines the outside and covers the inside. Well, this is the skin lining the inside of your windpipe. And this is comprised of pseudostratified ciliated columnar. That's where the air is moving through. So there's this snot lining this layer, collecting all the dirt that didn't get stuck in your nose. This is that C-shaped piece of tracheal cartilage, right? That yellow band right there is simply looking down on top of one of these things right here. Those C-shaped bands of hyaline cartilage. It also lets you see right behind the trachea, right, is your esophagus. And it's kind of a good thing that the cartilage doesn't go all the way around, which would really be a good idea for reinforcement. But imagine trying to gulp your food and you want your esophagus to expand. And you're trying to bulge into a ring of cartilage. That wouldn't feel very good, right? So it kind of gives a little bit when you're actually trying to gulp your food down and get large masses of boluses going down your esophagus. Kind of a little bit of a benefit there that there's no cartilage there. But there's your common carotid, right? Another carotid over there. Let's look at that epithelium that lines your trachea. That's what this is. That's your pseudostratified. Those are the goblet cells. And remember, it's pseudostratified, and you have to say this, with cilia. That's the most important idea, with cilia. You have to pause for a moment. Do you remember the difference between cilia and microvilli? Cilia move.
Longer.
What are cilia comprised of?
They are
They're not-
flagellae.
They're
Embryonic
not
flagella.
extensions, right?
Well, flagella is what's a flagella made up of?
It's a protein core with a membrane around it. You know, eukaryote.
You guys remember microtubules? The pair of two wrapped by around 9 pairs of twos. Oh, okay. So, in other words, they're microtubules that can move. And they're moving always in like a sea anemone upwards motion, like an escalator effect. And they're trying to move the mucus upwards towards your oropharynx, towards your mouth, for you to cough up that mucus. So you might notice yourself when you're not really paying attention and just kind of just do a little light, right? That's you getting rid of the mucus that your body's been moving up, containing all that dirt and pathogens. And then you usually just swallow it. I mean, it's just glycoproteins and dirt, just carbs and protein. That's all it really is, right? But now the important thing is the cilia, right? They like to beat up, constantly moving up the dirty mucus. We keep making new mucus. We have a nice, clean, fresh layer of that sort of hepatic filter or hepatofiltering system. The flypaper-like idea. But smoking can damage those cilia. Smoking can paralyze them. Now the idea is that it's a chronic long-term smoking issue. All right, great. What is chronic long-term smoking? It all depends on what you smoke, how you smoke it, how long you smoke it. For example, my dad, up until 1968, I think it was a 2-pack-a-day Camel smoker. Damn is right, all right? We had all kinds of Raleigh coupons. Used to get toasters and microwaves and not microwaves, they didn't exist back then, but other things, toaster ovens, blenders. And then he quit cold turkey. Hasn't smoked since. And his lungs are perfectly fine, right? But some degree of chronic long-term smoking paralyzes these cilia, and they won't replace themselves. So you have that infamous smoker's hack. You guys ever heard of someone with a smoker's hack? Right? That really hard, violent, you hear the phlegm vibrating. Since they don't have the cilia, they have to physically shake loose the mucus, then have enough airflow to push the mucus up to their mouth, and then expel it out. That's why it comes in large amounts, not just little teeny unnoticeable volumes, but significantly large portions of bolus, because they don't have the escalator. So they mimic it by coughing hard, that shakes their trachea, and then the airflow helps to push that mucus up. That's the only way to get rid of it. Otherwise, it accumulates in your trachea, it might drip down into your lungs and create pneumonia. So your body constantly just forcibly makes you cough that stuff up. Now we're getting smaller and smaller. What I want you to notice is, and think about, there's my rings of hyaline cartilage, still in my primary rings of hyaline cartilage. There's a secondary branch right here, right? There's a secondary branch right here, right? But then these are going to be called tertiaries, because the third set of branching, right? First set of branching, second set of branching, third set of branching. But look what's happening to my rings of cartilage. Now they're becoming plates and scales and scabs and little spots, and then they're gone. So as we work our way further and further along this bronchial tree idea, right, the amount of cartilage gets smaller and smaller, less and less, until we get to the bronchioles level. And at that point on, there's no more cartilage. It no longer is present. What will begin to show up is bands of smooth muscle tissue. So we're replacing the cartilage with smooth muscle tissue. And we'll see that in an upcoming picture. Now, primary bronchi lead to what? The lungs. Secondaries lead to the lobes. We have 2 lobes on the left, and how many on the right? 3. So a total of 5 secondary branches, right? Now we get even smaller. We get to the tertiaries. And what do tertiaries lead to? Bronchopulmonary segments, right? It says so right. That's how I know, right? You think I know this stuff? I just read the slide before you guys do, right? Now the question is, what in God's name are bronchopulmonary segments? We'll get to those in a second, right? But you memorize that tertiaries will lead to that. All right, here's a diagram for us to see our secondaries with a little more clearly. I know that's the trachea. I know that's a primary. I know that's a primary. I know that's the secondary branching right there, and there's another secondary branching right there. So gold and blue, I only have 2 colors, right? Only 2 sets of secondaries. How many colors on that side? 3. Now here's the difference. See how this hasn't changed colors? That means all of that is primary. Right? Yeah, that's the secondary right there, but this isn't secondary, right? The secondaries are at the terminal end of this, because they have to go down to get to the middle and inferior lobes. So the primary is a little bit longer on the right side than it is on the left. To have further down to go, so I have to get down to that bottom lobe down there. Now, I want you to think about doing lung surgery as being an arborist, someone who takes care of trees or pruning. I can learn my anatomy, and I can take my little snippers and snip wherever I want and remove smaller portions of lung tissue without affecting other structures. So we're getting down to this idea of what's called bronchopulmonary segments, which are these. Do not memorize this. All right? I'm trying to think of who's not here. I think everybody's here. All right? If somebody was not here, tell them that John wants us to memorize all these things. Okay? But here's the idea. I can see superior lobe, right? Fed by a secondary bronchi. Middle lobe, fed by a secondary bronchi. The inferior lobe, fed by a secondary bronchi. But every color is fed by a tertiary branch coming off of that secondary. The idea is that every single color is a self-sufficient segment of lung tissue. I can remove it without affecting the neighboring regions. Right? Sort of like the Titanic, but successful. Okay? Now, here's how you can do it, right? If I go back to this idea, we'll talk about these in a second. If I have damage, let's say, to this part right here, then I can simply take my scalpel and snip these little tertiaries off and remove that little piece without bothering the other little tertiary segments. To put it in somewhat of a historical context, let's say we're looking at the Civil War, since a lot of surgical advance happened because of war. That's where our first MASH unit came. If I got shot with a musket ball on this side of my chest, they removed the whole lung. They didn't know any better. Just take the whole damn thing out. Then probably by about World War II, we got, oh wait, if John got shot here, we don't need to remove the whole lung. We can keep the two lower, we're just going to remove the top part. And then by today, some trauma, stab wound, bullet wound, fragment of shrapnel, whatever it is, hits me right here, then I don't have to remove the superior lobe. All I have to do is remove the portion that was actually infected or damaged. So remove the one bronchopulmonary segment, the green and the lime color, still stay in place. They still work because they're not connected to each other. So I can simply remove one little piece of those. And that's the whole benefit of the bronchopulmonary segments. There's about 10 on this side and 8 to 10 on the left side. It varies with people. Some people have 9, some people have 10. But it simply allows me to remove that one little portion of lung tissue without affecting the neighboring ones. You don't have to learn all the different names unless you become a respiratory therapist, then you'll learn all the various names.
Is there any benefit to having 10 in the left lung versus 8, or does it not matter at all?
No, the first idea was, well, because the heart grew here, that influenced how many segments there were going to be. And since we have just normal anomalies in structure, some folks obey the 8 rule. Some say, oh, we're going to squeeze one more just for the heck of it in our system in there.
Okay, but it doesn't do anything?
No. I mean, it might be a little bit more beneficial to you. I mean, some folks have 2 inferior vena cavas. It really freaks you out when you're in there. Okay? Now, let's get down to the microstructure. I know I have a trachea going to primary. Primaries go to secondaries. Secondaries go to tertiaries. And the amount of cartilage is getting less and less and less. And the tertiaries branch to these things called bronchioles, where I have no longer any cartilage whatsoever. But now we're at the level of, right, the bronchiole, and there's my smooth muscle tissue wrapping around them. Right? That means that with smooth muscle tissue, I get to do the same thing as I could with an arteriole. What can I do to arterioles? I can change their diameter, right? So if I want to keep poisonous gases from going into my lungs or really cold air, I can constrict those muscles and block off the flow of air to that part of my bronchopulmonary segment. Right? Or if you have an allergic reaction to pollen, get asthma, right? Bronchitis. Do you know anybody with a little inhaler? Yeah. Right? Notice how they use it. They don't squirt it in their mouth. What do they do as they depress the plunger? They suck it in, right, to get the medicine all the way down so it can cause basal, or basically bronchial dilation. It's got a steroid in it to make the muscles relax. If the muscles relax, the tube relaxes, and as tubes get larger, what happens to resistance? It goes down, so it's easier for the air to flow in. And it's within a couple of seconds. That stuff works really, really fast. But we can also see right at the beginning of our respiratory, right? So this idea right here of respiratory bronchiole, if we just back up for a moment, get all the way back to here, right? We're right here at the beginning of our respiratory zone. And we're looking at the structure of this little mass of lung tissue. Up until here, it's always been a conducting zone, getting the air to that part of our structure. Now, I have what I think is a really good analogy if you guys can think about this. So go to the grocery store tomorrow, or on the way home if you want. I want you to grab a cluster of grapes by the stem. The stem can be our terminal bronchiole. Look down the branching to the very first isolated set of grapes that are all by themselves. That can be these guys up here. Each one of these can be a grape. Right? Each one of these will be then an alveolus. A little teeny, mini little lung. Take your grapes home, wash them, take a dental rubber band from the orthodontist, one for braces, the little teeny little buggers, and wrap several of them around the outside of each little grape. Right? What do you notice happening to the grape? You're kind of squishing it, right? Because of the contractility of the little rubber bands. Well, they represent the elastic tissue around each and every one of these alveoluses. Right? That's significant, because what does the elastic tissue not want to do? It doesn't want to stretch. And when you do give it stretch, it wants to always recoil back to a smaller size. Right? That'll be significant in helping us ventilate our lungs. So you have lots of rubber bands around the grapes. Now, on top of rubber bands, get a hairnet and cover the hairnet around each individual grape. The hairnet represents the capillary beds. Now you have a really good working model of your lungs. Snip one little chunk, one little cluster of grapes off with the rubber bands around them and the hairnets, and you have an alveolar sac, right? A collection of alveoluses, of individual grapes. Each one surrounded by connective tissue, which we'll talk about the significance of that next time, but also each one connected by or covered by a capillary bed. And remember, the capillary bed is surrounding every single one of these little structures. So when we look inside of one of these structures, it looks like this. This is one of those structures. Here's my capillary bed, kind of maybe looping like this and coming around like this. They just cut it in half, like we did for the capillary bed. We're looking down inside of a bowl-like structure. So you can see the top of every single simple squamous epithelial cell that actually makes up the literal wall, right? I mean, that's what this is, right? This is the wall of this grape-like structure. And you recognize it's simple squamous. So that's the epithelial name, but they also name these cells, like George and David and Tom. They call them pneumocyte type 1s. Every single one of these is a pneumocyte type 1. I want to begin to help you think about this in terms of logic. Why are they called pneumocyte type 1s? Probably because what? There's a type 2, right? They're not simply called pneumocytes, otherwise they'd be just simply pneumocytes. So when someone takes the trouble to call them type 1s, you got to go, where the heck are the type 2s? And that's these guys right over here, the gold ones, right? Those are pneumocyte type 2s. And there's several of them, right, in each alveolus structure. Well, yeah, I mean, a lot of people don't really refer to them as pneumocyte types 2. They're actually known as septal cells. That's the more common name, a name you're going to want to know. Now, what do septal cells produce? They produce this red word called surfactant. You want to emphasize the fact, right? Surfactant. It's a lipid-like solution coming from our septal cells. What does surfactant do? What am I saying right here?
Hydrogen bonding.
But what about hydrogen bonding?
Decrease.
I'm decreasing hydrogen bonding.
Decrease the surface tension of
Oh,
water.
well, hang on, we'll get there. Yep, you're right. I mean, that's the bottom line we'll get to in a second. All right? This Dave is jumping the gun just a little teeny bit, which is fine. That's good. Keeps me on my toes. All right? Now, hydrogen bonding. You guys should remember that. You remember the chemical definition of hydrogen bonding? The hydrogen atom of one molecule interacts with a very electronegative atom of another molecule. Right? Well, since water is our only solvent, it's the hydrogen of one water molecule forming a bond with the oxygen of a neighboring water molecule. Is, just out of curiosity, is this our weakest chemical bond that we have?
No.
Is there, what's a weaker chemical bond? Do you guys remember?
The van der Waals forces.
Right, exactly, right. So these are a little bit stronger than those guys.
That's what lipids have between each other.
Mm-hmm. Now, this is not very strong. All right? One hydrogen bond, I would not bet my life on at all. Right? Billions of them, though, because their strength in numbers, right, is quite significant. So this little diagram in black, which you guys want to now draw, is one alveolus. That black line is one alveolus, and it's lined with a little layer of water, represented by my purple line over here. Everybody's going to keep you guys glare or not?
Or like,
That fixed it.
All right?
Or Wednesday. I love Plato.
Now, I want you to visualize this. In every single one of your alveoluses is a thin layer of water. To experience this, I want you to go home tonight or tomorrow. When you take a shower next time, close the bathroom door and do not turn on the vent fan. Create your own little sauna in the bathroom. When you're done showering, what's on the mirror? Steam. In other words, condensation of water, a thin film of water. That's what's lining your alveoluses. And water has surface tension to it. Now let's break apart that word. Just humor me. What does surface refer to?
Area.
The surface exposed to
Now
air.
see, if you guys can't tell me what surface is, how are you going to describe this to someone? What is the surface of something?
An interface
It's the
between
top,
two
right? So this is the surface of the table. Okay, now the harder question, what is tension?
tendency of water to form balls.
No, not really, I mean, because steel has tension to it, doesn't it?
Between the particles at the surface
It's-
to each other.
Or is it
The force that prevents separation or pulling apart, like the tensile strength of steel, right? So, in other words, I have tension on the surface of water. Now, surfactant, coming from the septal cells, helps to decrease the hydrogen bonding of water, which is really decreasing the tension on the surface of water. We want to do this. We want to minimize the tension on the surface of water. That's because I'm trying to show you with this next little set of our diagram here. You see these black dotted lines, right, and my black arrows? I'm expanding my alveolus from the solid line to the dotted line. What happened to the size of my alveolus? It got bigger, right? But to do that, I had to break the tension of the surface of my water. And that's resisting me. It says, no, I don't want you to expand. And all my little hydrogen bonds are saying, no, please don't pull us apart. But I want to pull you apart. Otherwise, I can't expand my lungs. And we'll deal more with that in the physiology lecture. But this is to give you guys a bit of a head start because you guys seem to struggle with this idea of surface tension lining the inside of each alveolus. Another key idea is, are you guys familiar with premature babies have difficulty ventilating? Why? Why do you have a hard time breathing if they're born prematurely? Well, it isn't smaller lungs. I mean, you're in the right universe of topic, but it isn't smaller lungs.
The alveoli are smaller.
It's not the alveoli are smaller either.
The lungs are not developed.
So that's a better statement, but what do you mean the lungs aren't developed? What cells? See, here's the question. It isn't the type 1s. They're there. It's the type 2s. Septal cells don't show up until on the 28th week of embryonic, or I should say by now, a fetus. By fetal development. They don't begin to show up until the 28th week. So if I'm 29 weeks along and I pop out, my septal cells have just started to become developed. They're not producing surfactant. And I'm going to have a hard time being able to inhale. All right, so you want to keep it as long as you possibly can. And we'll talk more about the idea of premature babies' inability to inhale due to a lack of surfactant because of a lack of developed septal cells. And a really interesting treatment for them as well. So we're going to talk about buggers.
Well, that's what I was gonna ask, but if we're gonna talk about that later, it's fine.
Yeah, what's it called? Do you remember? Do you know?
I don't.
Ah, okay. So let me give you a little preview to what you're thinking about. Since I always like putting movies in your education. You had Indiana Jones on the exam. How many of you seen the movie The Abyss? All right, you're going to have to watch The Abyss again. There's a scene in there. There's actually 2 scenes we're going to talk about that are in that movie. One's real and one's fake. All right? But it's a way of treating this. Last little bit, because we'll talk about that premature baby issue a little bit later, is I want you to appreciate the difficulty of gas exchange in your lungs. And we'll define that Wednesday in lecture. But get your bearings for a moment, right? Here's the alveolar airspace, right? So what is this purple thing representing? Well, I know it's that because it says so, but what is that? What is this alveolar epithelium we're looking at? It's a cross section of one of these simple squamous cells, right? It's that right there. That's what it is. And look at what they're showing you in the diagram. We just mentioned this stuff, right? See that little blue line? That little faint blue line? That's water with surfactant. So if I'm an oxygen molecule, the very first thing I diffuse into is a layer of water. Right? And this is where I really push the idea of don't look, but look. If this is a pneumocyte type 1 cell, then what is this dark purple line representing actually?
Cell members.
A semi-permeable barrier. What's the light purple represent? The cytoplasm. What's that purple line? The other side of the cell, right? Then you got connective tissue. What's this red thing representing? What is endothelium? It's the simple squamous cell of the capillary. It's a cell, right? Don't cells have membranes? So what does this dark red line represent? The cell membrane. Cell cytoplasm. It's another cell membrane. Oh, here's plasma. What's this big red thing? Does it have a membrane? Yeah, it has another membrane. So imagine this. An oxygen molecule has to pass through a layer of water. 1, 2, 3, 4, 5 cell membranes to get to the hemoglobin inside the red blood cell. And how many barriers of liquid? Well, there's a layer of water, cytoplasm, cytoplasm, plasma, and then more cytoplasm. Right? This is like at the limit of oxygen's ability. So what were to happen now if I had a little layer of mucus lining the inside of my lung? You just increase the thickness I have to pass through. I may not be able to pass through. Right? Which is why people with pneumonia have a hard time ventilating. Right? Not every single one of their alveoluses has mucus in them, but the ones that do, they're not going to work very well. Because I'm at the brink of not being able to do this. Because you have all these lipid layers and all these boundaries of water to pass through. Hang in there, Scott. Am I boring you there, dude?
Oh, I'm spent.
You're spent. Holy cow. It's a good thing that we're done then, isn't it?
Yeah.
All right, ladies and gentlemen, that's your anatomy. All right, remember, it's not on Wednesday's test.
Thank you.